Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, ilerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.
Dear professors, speakers, and dear participants, welcome to our symposium. We are having the last of our scientific meetings this year within the Tissue Engineering and Biomaterial Research Center, which is one of the working subgroups of Near East University Center of Excellence. I would like to explain why we dedicated this topic of this meeting to the interaction of ionizing radiation with living things. Many of us can be exposed to ionizing radiation, although it is in low doses, without realizing it, and both in our daily lives, in our working lives, and we have a lot of confusing information we get from the media, including the fact that radiation is also used in cancer treatment, even though we know that it causes cancer, or we know the frequency of imaging examinations with the ionizing radiation during our health checkups. That's why we thought it would be helpful to discuss the right information about ionizing radiation with the experts to avoid the information pollution. Our professors from different faculties and disciplines of Near East University, as well as very valuable professors from Turkey, will attend our symposium during the sessions. We welcome questions and contributions from our listeners in an interactive way. In the hope that it will be useful to all of us, to start our first session, I would like to invite the Dean of the Faculty of Veterinary Medicine, Professor Dr. Deniz Seyrek İntaş, and Head of Tissue Engineering and Biomaterial Research Center, Professor Terin Adalı, please.
Welcome you all to our symposium related with the ionizating radiation and its effects on human health symposium. Our symposium chair, Prof. Dr. Meltem Nalça Andrew, is organized all these important presentations. Now I want to invite Prof. Dr. Doğan Bor to his presentation, to present his presentation. Prof. Dr. Doğan Bor completed his Bachelor of Science and Master of Science from Ankara University Faculty of Engineering Physics in 1976. He completed his PhD from Ankara University Nuclear Medicine Department and the University of Arvin Department of Radiological Sciences in between 1981 and 1985. Prof. Dr. Doğan Bor received his Associate Professor degree in 1990 and a Professor degree in Nuclear Medicine in 2000. He worked in Turkish Atomic Energy Agency in between 1984 and 1992 As an external expert and lecturer of the International Atomic Energy Agency, he worked in between the years 1988 and 2012. He's acting as a professor in Ankara University, Department of Engineering Physics, and founding director of the Institute of Nuclear Science and of Ankara University in between 2006 and 2012. He published 80 scientific papers in international peer-reviewed journals and editor of 3 scientific books. He has more than 150 presentations and invited talks at national and international meetings. It's an honor for us to invite Prof. Dr. Doğan Bor to present his presentation entitled Health Effects of Low-Level Ionizing Radiation. Yes, please. Prof. Dr. Doğan Bor.
Thank you, Dr. Adalı, for your kind introduction. Thank you very much, Dr. Meltem Nalça, for your kind invitation to this symposium. It's an honor for me to talk to you in this symposium. So let me open my PowerPoint now. No. Oh, sorry. Yes, here it is. And F5. Okay. Now, the topic of my speech is health effect on the low level of ionizing radiation. And I was told that some of the participants may not be familiar enough to the basic of the radiation physics. So I'm going to give you some introductions about them. And then I will talk about the radiation epidemiology and continue with the uncertainties about the low-level radiation effects and current research activities in the field. Radiation and electromagnetic waves. We live in a wave of the in an electromagnetic wave cloud. So the radiation and electromagnetic waves are the alternative terms, and radiation energy that comes from a source and travels through space at the speed of light. It moves in the form of waves or particles. This is a strange phenomenon indeed, both the wave and particle behavior of the radiation, but a simple analogy may be the grains of the sand with the waves in the sea beach. That's simple similarity. So this is the electromagnetic spectrum, and this is the ocean we live in, but we never see it. And the energy range is too wide, is 10 to 20, from lowest to highest. And the lowest energies are the radio waves, follows microwaves, infrared radiation, visible light, UV light, then X-rays, and the gamma rays. And I'm showing you in this slide some of the tools that uses electromagnetic energy, or the electromagnetic energy is produced. The important issue about this slide is that we divide the spectrum into 2 parts, non-ionizing radiation and ionizing radiation. What I meant with ionizing radiation, if the energy of the incoming radiation to a medium is enough to remove the electron from the atom, it is called ionizing radiation. So this is the high energy part. And for non-ionizing part, it only causes some vibration. But in my talk, I will focus to ionizing radiation. This is because the other is not probably a scope of another talk. So what is the source of ionizing radiation? It's the radioactivity. And some of the radionuclides, they have excess energy in their nucleus due to the imbalance of the nuclear forces inside. So the nucleus want to access this, want to give up this energy. So what it does is it releases radiations, and there are different type of radiations, for example, beta particle, they have negative charge. A similar one is the positron, but to beta particle, but with a positive charge. Neutron has no charge, and alpha particle are the heaviest one and the positive charge. And we have photons. Gamma rays are originating from the nucleus, and X-rays are originating from the orbital electrons. So the sources, we live in a background radiation. I mean, we are all the time exposed, and one of the main source of natural radiation is the terrestrial radionuclides in the Earth that are formed from the beginning of the Earth, millions of years ago. Uranium, thorium, polonium, all of them. But I would like to pay your attention to the radon gas. It is a radioactive gas. It is released by all the materials, constructed materials. So we inhalate it all the time.
Dear Hocam, I'm so sorry that I disturbed your presentation, but unfortunately your presentation is not on full screen, and other slides are not following your presentation. So
can you see it now? Can you see it now?
Yes, now we can be able to see the other slides, but would you please...
I did it. I was told that I have to activate F5 button, but I'll do it again.
All right, would you please open the full screen, Hocam?
Okay now? Is it okay now?
No, it's not on full screen. If you
it's full screen on my... It's full screen on my... computer. I don't know what. Let me try it again.
Right-hand side, Hocam, on the right-hand side at the bottom.
Here it is. I know.
Yes, here. If you click it.
Yes.
No. All right, but if you move slides, it will be better for the participants to follow your presentation.
But I already follow my slides. I mean, have you seen those slides before?
Not before, but now we can be able to see it. Thank you so much.
Okay, then I'm going to back and repeat it, okay?
Yes, it's okay. I apologize that I disturbed your presentation.
Sorry, but I don't think it is related to my computer because it worked many times. Anyway, let me go quickly, and please keep this time at my side. Okay.
Of course. Thank you, Hocam. You can continue.
Radiation is the energy that comes from a source and travels through the space at the speed of light. There is a wave and particle property, and a simple analogy is the grain of the sands that moves together with the waves at the sea beach. So it's a simple analogy. And this is the electromagnetic spectrum, and this is the energy range is too high, starting from radio waves and going micro, infrared, visible, UV, till to gamma rays with the highest energy part. And these are the tools that are working with electromagnetic waves or producing the electromagnetic waves. But the important issue about the spectrum is we divide it mainly to two parts: non-ionizing part and ionizing part. What is the ionization? Let me first explain you this. If the energy of a radiation interacting with the medium can remove one of the electron from the atom, we call it it's an ionization event. So the energy must be higher to damage the function of the atom, therefore the molecule. For the non-ionizing part, energy is so low and can only vibrate the electrons. And what is the source of the ionizing radiation? Is the radioactivity. Some of the nucleus, they have excess energy in their nucleus, and the nucleus wants to give up this excess energy by using some radiations like beta particles, positrons, neutrons, and alpha particles. They are different in their charge, electrical charge, as it is shown in the slide. and the photons, where the gamma rays are originating from the nucleus, and the X-rays originating from the orbital electrons. And what is the source of the radiation, the natural radiation? Because we are living in a background radiation, although we don't see it, but we are affected. There are two sources of this natural radiation. One is the terrestrial radionuclides, with uranium, thorium. And I would like to pay your attention to radon gas. It is a radioactive gas. It's in the air, and this is mainly originated from the construction materials, since they come from this earth materials. And the problem is this radon gas it emits alpha rays, alpha radiation, and when it absorbed by the lung, it may cause a lung cancer, although the probability is too low. But there is a very good evidence that the minors, the incidence of lung cancer for minors is not ignorable. And I would like to also suggest you, for those living in the basements, to ventilate their houses for 5 minutes. And bad news for smokers, alpha particles stick to smoke particles, and then the incidence, the probability of the lung cancer increases 20 times. It's well proven in the world, done by United States people. Another source of the radiation is the cosmic radiation. It increases with the altitude. For example, if you are traveling by plane in a 10 kilometer of altitude, you will be exposed 40 times more than the background radiation in the ground. But do not afraid again, because it is still too low. You're surrounded with background radiation. There are the foods and drinks. Some of them, they all include the radioactive materials. For example, one example is the banana. If you eat 100 pieces of banana, you will be exposed to potassium for the radiation. And this is almost equal to 1 day of background radiation. But do not afraid, because our metabolism immediately extracts this excessive potassium for the. I'm giving this example because how we are living together with the radiation. Our body, we are exposed from those outside, but we also expose the outside through the radionuclides in our body, in our muscles, bones, teeth, etc. So there's also man-made radiation sources for the benefit of human life, the medical applications, you guys all know very well, and industrial applications, technological applications, and unfortunately, for the disaster use of human life, the atomic bombs that I will be mentioning soon. And this is again, the electromagnetic spectrum. I like to define here the wavelength. It is the distance of the peak here. And this wavelength determines the interaction of these electromagnetic waves with the human body. If this wavelength is comparable in size to the body size, it is absorbed, or the size of the absorbing medium, let's say. In case of radio waves, there's no interaction. They pass us, because long, up to kilometer distance, this wavelengths. And then, if its size comparable to our body, it is absorbed, as I have told you, and causes electrical currents in the body. But do not afraid, it's still safe. And if a further decrease in the wavelength causes heat effect, as it is the case for mobile phones. And further going to visible part, the wavelength is comparable to the size of the sensitive cells of our eyes. So it is absorbed. This is why we see each other. So this is the part of this is the non-ionizing part. And this is the dominant mechanism here is the wave property of the electromagnetic waves. And the analogy is the sail and ship in a wave. And for the ionizing part, the wavelength becomes so smaller, then it starts to act as a particle. And the analogy is, it's very similar to the colliding of ball bearings. And the interaction takes place with our molecule where photochemical effect occurs, and then X-rays with orbit interaction with the orbital electron, and finally the smallest part, the nucleus, where the gamma rays are produced. So an important issue about the radiation is its dose. Its dose, because it is the main concern. And it is the energy of ionizing radiation absorbed per unit mass of any material. The unit is gray and joule per kilogram. And the dose depends upon the type of the radiation. And in case of an external exposure, do not worry about the alpha rays, because the air between us, they immediately stop. In case of beta rays or beta particles, they will be stopped at the skin, maybe few millimeters penetrate to that. But for photons, for gamma and X-rays, they penetrate through the body, and according to their energies, they will stop at different depths. If the energy is too high, they may even penetrate without any interaction. So if these radiations are stopped in the body, they cause ionization. Some free electrons are produced. Number is proportional here with the energy, and this causes the absorbed energy and therefore the radiation dose. But there are some other factors affecting the radiation dose, and one is the intensity, and the other one duration of exposure, and also the composition of the medium, the thicknesses, and its atomic numbers affect the dose. But if it is for example, the intensity of radiation means that the number of particles in radiation beam. If there are higher number of particles in a beam in comparison to the lower numbers, the radiation dose delivered to body will be higher. And you can treat the intensity as the illumination lamp. For example, a 100-watt lamp, its brightness will be much higher than, for example, 40-watt lamp. Okay, here in this slide, the beams have equal energy, but you see on the left, since the intensity is higher, the dose will be higher. And in case of the internal exposure, this may happen because of the contamination of the skin with radioactive materials or intake of radiation source. If the isotope is beta or alpha, you are in trouble. All the energy will be deposited in the body. However, if it is for gamma rays and if it is for medical diagnosis, it is okay. You can recall the nuclear medicine applications. Assessment of the cancer risk due to the radiation exposure. The question is, do we have a unique technique? Which link the and radiation exposure to a cancer disease? No, there is no unique technique. There is a long latent time for the occurrence of cancer disease after the radiation interaction. This is almost 5 years for leukemia, and it is up to lifetime for solid organ cancers. And it's not possible to relate today's cancer case to a past exposure, because the person during this time interval may be exposed to many other cancerogenic factors. And we need some evidence, some physical and biophysical evidence for the probability of radiation occurring cancer. Okay, if the electron is removed from the DNA molecule, then the DNA will be damaged and it may go to cancer. And this is there must be a minimum energy requirement for this event to occur. This is between 0.5 to 30 electron volt. So this is the theoretical basis. But there are some animal experiments providing us very valuable data However, it's not possible to project them to the human studies. And also, the hot topic is in vitro research. What people are irradiating small tissue samples and investigating the function of the cells, but again, the projection of this result, the whole organism, is not always possible. The main technique is the epidemiological studies. What is? So we have an exposed population, with yellow circles, and a control group. And the health status of those persons included in this cohort followed for many years. And the cancer cases are counted for each group. If the number is high for the exposed population, then this may be attributable to the radiation. Still, there are many drawbacks because the lifestyle of these two groups, the exposed population and control group, should be similar to each other. Also, the past exposure has to be taken care of. Also, the gender, latent time, other carcinogenic factors, those are should be very similar between these two groups. And how we started to learn the effect of radiation to human health. This is the unfortunate atomic bomb blast in Hiroshima and Nagasaki in Japan. And there were more than 230,000 people immediately dead due to the heat blast and radiation effect. And we know very well the high level of radiation effects, the tissue reactions. This will be covered by Dr. Nalcha, I think. And also there are some late effects, the cancer and the genetic effects. But what people did was they did some epidemiological studies. They started at 1950 and still continues. Now I'm going to give you a number and you will be surprised probably. The number of incident cancers counted after 1950 to 2017 is a bit less than 1,900, I think, 85. This is the number 2017. And data is still coming because 1/4 of these victims are still in life. And this is the result of the Japanese work. And here is the radiation dose and the excess relative risk, the risk due to the cancer. And you see from very low radiation to high radiation, the response is linear, and the risk per grade, which is a high dose, is 0.47. So this is indeed become the basis for today's radiation protection philosophy. But as I have told you, we have low doses here and high doses here, but we are more interested with the low doses. Why? Because the natural radiation we live in, because of the occupational exposures, people working with radiation are exposed to radiation. And the medical and the patients undergoing diagnostic examinations, nuclear medicine examinations, with the exception of interventional cardiology and radiology studies. Those are higher over there. So millions of people are exposed to radiation every day. So what are the risks? In risk calculations, what they did is they calculate the risks from the slope of this linear curve, and they assume that the risks are lower for low radiation, and then they extrapolate it by dividing by numbers, such as like 2 or 3. But if I magnify the low dose region, it's not linear now. The linearity theory is dropped. So the question comes, let's make an epidemiological investigation for this group, for low dose victims, but it's not possible because there are many inherent drawbacks, many biases, many confounding factors of the epidemiological studies. And the most important one is the uncertainties for the assessment of the individual dose estimates. In order to have a reliable statistic of an epidemiological study, and if you are searching for 10 millisievert, which is the dose received during a CT scan, you got to expose 10 million people and also the control group. This is impractical. No way out. So there are some now uncertainties on the low level part, and one is the shape of the curve. Is it linear? There are a lot of hypotheses. Supralinearity, some people suggest that there's a threshold. Some are suggest that there's a hermetic effect. Radiation is good for your health. And second unknown is what is this range, this low level range? Is it really starting from zero, but we are living in a background radiation? How come? And how extends it go through the high energies? 50 milligray, 100 milligray, what is it? So there were these unknowns. However, there should be a decision to be made for the radiation protection philosophy. And the ICRP, the International Committee on Radiation Protection, advised that stay in secure site. Many countries, probably the majority, establishes their regulations according to the advice of the ICRP. So they say that dose range is lower than 100 milligray, dose rate range is less than 5 milligray per hour, dose response is linear, forget about the hermetic or threshold effect, and you got to divide the risk factors by 2 in order to get the risk factors for low dose radiation. And the cancer risk is 5% for 1 sievert. What it means, if you expose 100 people with 1 sievert of radiation dose, 5 of them may get cancer in the remaining of their life. But this 1 sievert is too high. For example, for the chest exam, the dose is 1,000,000 times less. So if you expose, dear participants, 1 million person, only 2 or 3 of them has the probability of getting cancer in their lifetime. And this risk increases for the abdomen study of the computed tomography. Dose is higher, and it goes up to 500 in 1 million. And keep in mind that 400,000 people will get cancer due to the other cancerogenic factors. The percentage is 40 for the developed countries. And unfortunately, the 20 to 25% of them are dying. The contribution of the radiation is only 1%. So we are in chaos now, and a lot of research is going on. And I would like to mention 2 important meta-analyses. First, what is the meta-analysis? As I have told you, it's not easy to make epidemiological study specific to one exposed group because of the uncertainties. So what people do that, they collect the information from individual epidemiological studies aiming to same purpose, and pull the data and evaluate the results with some statistical algorithms, and then conclude. So what they do is finally is they improve the statistic. And one study showed us that the exaggerative risk for 100 milligray is 0.02, almost 29. It is more or less same with the Japanese victims, where they collected the data from environmentally exposed people, from medically exposed people, and from occupationally exposed people. So this is very new study. And it really, impressive. And now we are saying that the doses below 100 milligray is not free of risk. Another test was the linearity support of the dose response. As I told you, there are many other hypotheses. And NCRP made a study using the similar exposed groups, and they recommend to use the factor of 2 or 3 for the extrapolation of the risks. So majority of the studies strongly or moderately support the linearity hypothesis. Monday night, I was preparing my slides, and then a mail dropped to my email box, and it was about the result of the Epidemiology cohort study. We were really looking for it because this is one of the largest and reliable study investigating cancer risk of children in CT examinations. I'm not going through the details. It's in my slides. You may look later on, but it is risky, even for doses for less than 50 milligray. And risk for 100 milligray is 1.27 for brain cancer and 1.11 for the glioma. And this is if there is some repetitive scan to patients, the risk goes up to 6 times more. This is quite important indeed. And one other study is for the adults. For the adults, the risk, as you all know, the cancer risk against radiation is too low. However, what they did was they collected data from those that expose more than 1 CT scans and look at doses. And if it is taken in a day or in 2 days, where the repair mechanism of the body is not well functioning yet, it is indeed very risky. The dose goes up to grade 2.3. It's a lot of dose for breast. So we have risk. Children are more in risk for the CT exposure. And now I think I have time. Let me show you this slide. This is shows the cumulative doses in OECD countries. Look at where the Turkey is. And I don't know where this data is taken, but I'm sure it is correct. In Turkey, we are giving high radiation doses to our patients. And if you look at our publications, you will see in different applications how the patient and worker doses were so high. Anyway, now let's come to the new paradigm of radiation biology. The classical single target theory say that biological damage occurs only in the heated cell. Mutations are passed through the progeny of this cell only. Response is linear and clonal. But the new theory established under the research of in vitro studies shows a system response. This is because the biological damage occurs not only in the directly heated cell, but also in the cells that are not hit directly by the radiation. So the damage is propagated through all the cells in the neighborhood. So response is not linear and not clonal. The physical volume of the interaction is less than the biological volume that are affected by the radiation. This is a non-targeted radiation effect. Probably many of you know the bystander effect. It is a non-target effect. And it is the radiation-induced effects observed in unirradiated cells that are in close proximity to irradiated cells as a result of communication with the irradiated cells. So cells are communicated with each other due to the gap junction. There are some other methods that's not the topic of this talk. And other non-target effect is the genomic instability. It is a long-term increase in the rate of genetic changes in the genome of the irradiated cell over many cell generations. But let me emphasize a point here. This is the result of animal and in vitro studies because you cannot easily irradiate the small portion of the patient and then search for the function of the cells. So you got to rely on the results of the in vitro studies. But the question comes, is there any genetic effect of the Japanese victim? They searched for 70,000 person, and no genetic effect have demonstrated up to now. But the idea is now maybe you don't see it in the first generations, but this comes many generations after. So the research is underway. The genomic instability and the bystander effect is one thing in common. As I told you, the irradiated cells, they create some mutations and cell death, and then it causes micronucleosis and chromosome aberrations in the dyscandric cells. But the new thing is about this issue, the bystander cells, even not hit by the radiation, they also cause genomic instability. This is a very new area in research. And one other thing is the genetic and epigenetic effects of ionizing radiation. Probably you see the papers, they all after 2019 or 2020. What happens in the genetic effect, they then are damaged directly or indirectly, mutation occurs, and outcome is altered gen production. For the epigenetic, radiation silences some of the gens. For example, P53 gen. This gen is responsible from the suppression of the tumor propagation. So this may lead to a cancer, and also it affects the amount of the materials. Affect the number of the metals around the DNA, which is also maybe a cause for inflammation. So outcome again is the alteration of the gen product. I'm telling you, this is not proven yet for the human. So, as I've told you, those energy and the type of radiation causes oxidative stress, lesions in DNA, RNA, and the proteins. However, our metabolic stress and chemical, physical, environmental factors, for example, some benzene, some hydrocarbon, also generates the same damages in our body. They all transferred, propagated to other cells, and initiate the chronic inflammation, and the final outcome is cancer and other disease. So we can't, there is no way to understand that, okay, this amount of radiation causes this cancer, because the effects are all similar. And the new research is now evaluating all these factors all together. And we will see it as a cause. And probably it's one of my last slide. Is low-level radiation beneficial for our health? There are a lot of indications for this. For example, all the living things evolved with the background radiation. Our ancestors were living in a background radiation much higher than today's background radiation. It enhanced the production of the cell nucleus for the repair enzymes for damaged DNAs, show mitosis, I'm going to quite shortly, and enhance production of antioxidant enzymes. Bystander effects, they, as I have told you, they are one of the reasons initiating the cancer, but they may also have some useful effect because of they cause apoptosis. If a cell is hit by radiation, send a signal to other cell and say that, hey, I am hit, kill yourself. And also enhance the immune surveillance. So we are in chaos. Indeed, we are in chaos. And do we need a new radiation protection system now that will take into account non-target effects, the genetic, the epigenetic, the historical dose, and the individual radiation sensitivity. You all know that from the radiation therapy applications, the hyperradiation sensitivity and high radiation resistance. And one idea is a specific radiation protection for each individual, but it is in theory, it's impossible in practice. So thank you very much for your kind attention. I hope my presentation will be helpful for you. Thank you. Hello?
Yes. Good morning, everybody. I'm very happy to welcome you also to our ionizing radiation symposium. I think it's my turn now to take the chair for this next session. I wonder if there are any questions to our previous speaker, Professor Doğan Bor. Are there any questions I have to look? Yes, Professor Dr. Terin Adalı has a question. Can I get this question, please? Yes, please.
Hocam, first of all, thank you so much for this perfect presentation.
Thank you.
Now, for the last slide, you talk about new radiation protection systems. But what we know that there are radiotheranostic agents that have both diagnostic and therapeutic effect, and in the design of these radiotheranostic nanoparticles, they use radioactive agents to target. But I'm very interested with the last slide of yours that you mentioned that non-target effects is very important as a new trend in this research area. So what do you think about the radioactive and theranostic agents at nano level?
I think I can't give you a complete answer because it's not my topic, the nanomaterials, the radiation effects over there. But I emphasize the non-targeted effect, but I never underestimate the effect of the real target effect. Because now it is the concern, since you are exposing one part of the tissue, and what about the remainders? And this is now the main concern, especially the genetic effects now, although it is not proven for the human.
Thank you so much, Hocam. Thank you.
You're welcome. You're welcome. Any other question that I may answer?
I think there are no questions, no further questions. Yes, then thank you very much, Professor Doğan Bor. We enjoyed your speech very much. And thank you for your invaluable information you gave to us.
Thank you very much again for your kind invitation.
Yes, then I would like to proceed to our next speaker. And I'm very happy to announce that Professor Dr. Meltem Nalcha-Andrieu is going to do her speech. But before she starts, I would like to introduce her. She graduated from the Medical School of Ankara in 1987. She completed her residency in the Radiation Oncology Department of Ankara University in 1993 and worked as a specialist in Ankara Demet Evler Oncology Hospital until 1999. During that period, she visited and got training in the radiation oncology and brachytherapy departments of Royal Marsden Hospital in London, Institut Pauli Calmet in Marseille, and Institut Gustave Roussy in Paris. She was back to the radiation oncology department of Ankara University in 1999 as a lecturer and became an assistant professor in 2002. She had the title of associate professor in 2005 and was assigned as a professor in 2010 in the same department, which she worked until 2012. She currently works in the Radiation Oncology Department in the Near East University Faculty of Medicine. Professor Dr. Meltem Nalçı-Andrieu attended 12 international and 26 national scientific courses about her specialty, and she was invited to many national and international congresses and meetings as a speaker or chairman. She has more than a total of 60 scientific articles and book chapters in national and international journals and books. And now she's going to tell us about radiobiological interaction of ionizing radiation with normal human cells and tumor cells. Thank you very much, Professor Dr. Meltem Nalçı-Andrieu, for joining our symposium and of course of organizing everything. Now, I would like to invite you to make your speech, please.
Thank you very much, Professor Intash. So I'm very happy also to be in this symposium with all of you, such valuable speakers and professors. So I want to talk about the radiobiological interaction of ionizing radiation with the normal human cells and the tumor cells, because we use radiation to kill the tumor cells. So first of all, we have to say, what is radiation biology? It is the study of the effects of ionized radiation on biological systems. And how we learn about it, how we get the data about all these effects. Professor Bohr also talked a little about it, but mainly from the translational researches, especially on animals and tissue models, and also very first radiologists, because they didn't know the effects and they had a lot of injury with the radiation. Atomic bomb survivors, huge radiation accidents. We took a lot of data from the survivors of these accidents. And also, of course, for many years, we followed the patients underwent radiotherapy, and we have seen the side effects of radiation. So the damage by ionizing radiation is mainly the injury to DNA. This is the primary mechanism, and ionizing radiation is killing the cells. So most DNA damage may be repaired, but the lethal double-strand breaks are thought to persist, cause micronuclei formation, chromosome aberrations, and cell death through loss of the reproductive integrity of the cell's genome. So there are two kinds of action, in fact. There is indirect action, which is making the most of this action, and also the direct action. And indirect action is through the free radicals, in fact. And it is since the cells are made up largely of water, most of the free radicals are hydroxyl radicals, and most of DNA damage is therefore indirect through these hydroxyl radicals. But it is also important the presence of the oxygen in the cell, because the oxygen free radicals, derivatives like hydroperoxide free radicals are living longer than the hydroxyl radicals, and they have the probability to reach to the nucleus, and they form more serious damage which cannot be repaired by the cell. So if we want to give more damage to the tumor, we need oxygen in the cell. So I show this just to show how short it is, all these reactions. The first reaction is the ionization of the atoms, and this is the physical reaction. The second one is the physiochemical reaction. The free radicals are making the DNA damage. And the third one is the biochemical reaction. It is between 1 second and to several hours. But the last event is the biologic reaction, the event, which shows us the result, in fact. And it can take from hours to years. So it means we can see the results of ionized radiation exposure after so many years, even 10, 15, or 20 years. So that's why we have to wait for that. We cannot be sure immediately what is the action and the result. And the second type of action is the direct action. And we have it more with the densely ionizing high linear energy transfer radiations like the particles, neutrons, and heavy particles. And most of the time, this reaction is making the double strand breaks, and it is more lethal for the cell. So what is linear energy transfer? Linear energy transfer is the energy, the particle or the wave is transferring to a specific distance in the medium. So we know that the heavier the particle, the higher is linear energy transfer. As you can see here, the coupled 60 gamma rays are not does not have too much higher linear energy transfer, but alpha particles, they are very heavy particles and they are transferring too much energy, and they are making a direct action on the cells, and they can create more harmful damage which cannot be repaired. And at the end of these biochemical reactions, there may be lethal and mutagenic effects of small doses of radiation, and mainly dependent on the DNA damage. There may be double helix strand breaks, base damage and losses, formation of regions of denaturation, and crosslinks. So as a result, this is like a summary of the or what is happening with the electromagnetic ionized radiation or the particles. We are having ionization and excitation with the chemical change, mostly with free radical formation. This is around 85% of the action in the body. And at the end, with the DNA damage, we have a biological change, which may be the malignant transformation of the cells, or mutations, or the inhibition of cell division. So Dr. Bohr mainly talked about this malignant transformation, and I would like to talk mainly about the inhibition of cell division, which is causing side effects of radiation or the tumor control when we give it as a treatment. So, as at the beginning I told that there is a controversy about a concept that we can have cancer with radiation, but also we use radiation for cancer treatment. So For that, I have to talk about a little the therapeutic ratio, because it is the most fundamental concept, in a sense, a risk versus benefit approach to plan a radiotherapy regimen. We need an acceptable probability of radiation-induced complication in a normal tissue and the probability of tumor control to apply a radiation treatment for cancer. So we can best illustrate it with the graphics that these are the dose response curves, and the blue one is for the normal tissue and the other one is for the tumor control. They are showing the probability of the effect with the doses. And in this graphic, we can see that if we want to have a tumor control, we need a 95% probability of effect. But when we have it, as you can see here, the normal tissue complications are almost 100%. So this case is not acceptable to make radiotherapy. This is an unfavorable therapeutic ratio. And here the second graphic is showing more favorable therapeutic ratio. The curves change place, but if we want a tumor control, in this case, we will have almost 50% probability of normal tissue complications. So we can use radiation only for the case of there is no other opportunity for this patient. And the third one is the optimal therapeutic ratio. It means that when we are having the tumor control with a very high probability, desirable probability, and at that time, we have an acceptable risk of normal tissue complications, which is most of the time less than 5%. So for the cancer treatment, we are using radiotherapy for this kind of optimal therapeutic ratio cases. So to obtain this optimal therapeutic ratio, what we have to do? We know that we have to use fractionation for radiotherapy, which is affected by the biological factors, because if we give it once, we will have too much side effects, and maybe we will not be able to kill all the tumors. So I would like to explain a little about that. We have 5R of radiation biology we use in radiotherapy. That one is the repair of cellular damage, and the second is the reoxygenation of the tumor, redistribution within the cell cycle, repopulation of cells, and radiosensitivity of the tumor. So the first one, repair, we have in fact 3 kinds of damage in the cell after radiation. The first one is the lethal damage, and most of the time we have it with the double-strand breaks. It is irreversible, these breaks, and it is fatal, and it is increasing at high doses and high linear energy transfer. The second one is the potentially lethal damage repair. This is lethal unless specific post-irradiation conditions. And the third one is the sublethal damage repair, which is our concern, which can be repaired. So the damages which cannot produce cell killing yet are sublethal. Sublethal damage only became lethal when it interacted with additional sublethal damage. So it means that there must be accumulation of the fractions of doses to make it lethal. And this repair depends on some factors, which is the time, and that there must be minimum 6 hours between 2 fractions, and cell cycle phase and dose rate, dose and the radiation type. So I don't want to go into the details, But what we have to know is the sublethal damage repair of normal cells are better than the repair of tumor cells. So it means that during the period of between two fractions, the normal cells has the capacity to repair themselves, but the tumor cells, most of them, they don't. So it is an advantage for us to give the radiation as in fractions to have less side effects because of the better sublethal damage in the normal tissues. So we all know what is a cell cycle and what the cells are doing. The cells in the body are proliferating, or they can be too much differentiated to make a specific function. And in this case, they are not proliferating. They may be sterile. They may be dead, of course, or they may be resting in the G0 phase. So what we are interested in is this proliferating phase, because the ionized radiation is affecting the cells in the cell cycle, and most of the death we have is the kind of mitotic death, because we know that there are many kinds of death for the cells. That it may be interphase death, or apoptotic death, or necrotic death. So we know that it is important for us in which phase is the cell when we are giving the radiation fraction. So the most sensitive phase to radiation is G2 and mitosis phases, and the most resistant phase is synthesis phase, because at this phase the cell has so many material normally supposed to use for the DNA synthesis. But if we shoot at that phase, the cell can use all this material to repair itself. But at the late phases of G2 and mitosis, there is no material rest anymore, because the second DNA is synthesized, and the cell cannot repair itself. So it means that if we shoot at that phase, it is more lethal. We can have more damage to the cell. So right after the first dose of radiotherapy, the surviving cells are in resistant phase, and in a few hours later, they move towards the sensitive phases. If we cannot kill them in the resistant phase, they will continue to their circle. And during the course of multifraction, because of a buildup of radiation-induced cell cycle blocks and delays, a net sensitizing effect occurs. It means that with the second hit, we will find them in the more sensitive phase, so that we can give more damage. The tumors comprise heterogeneous cell populations at the different phases of the cell cycle, and they have a shorter cycle time compared to the normal tissues. So the redistribution in the cell cycle occurs more quickly in the tumors, and this is an advantage for late responding normal tissues. So it means that we can kill the tumor cells because of the redistribution when we are giving the radiation in fractions. And the third factor was the reoxygenization. And before that, I have to talk about hypoxia in the cells. Mainly in the body, there are two kinds of hypoxia. One is the perfusion-limited acute hypoxia, which happens after the obstruction of the blood vessels. For example, myocard infarctus is something like that. You know, there is an obstruction, occlusion in the blood vessel, and under this level, none of the cells can take oxygen anymore and they die. And there is another one, diffusion-limited chronic hypoxia, which means that the oxygen is going through the cells with a diffusion. And we know that the tumor cells are proliferating fastly, rapidly, especially some of them. So it means that when they are growing, they are increasing their number, cell number. They are as a response, they try to increase also the vascularization. We call that angiogenesis of the tumors because they know that they will die if there are no new vascularization. But still, for the very fast, very rapidly growing tumors, it is not enough to have new vascularization. So it means that the cells close to the vessels are normoxic. They have normal oxygen levels, but the one which is far away, they are hypoxic because the diffusion is not enough to them because of the distance. And they have a chronically low oxygen tension, these tumor cells. So when they don't have oxygen, as I told before, they are clonogenic and radioresistant because of the hypoxia, because we know that when there is oxygen, we can give more damage. The free radicals are more resistant, and we can give more damage to the tumor cells. So after this information, what is happening when we are giving radiation in fractions is with the first hit, we kill the normoxic the blood vessels. But until the second, third, or fourth fraction, as we kill the peripheric side of the cells, we know that they will die, and the other hypoxic cells will become closer to the blood vessels. So it means that with the other hits of the radiation, we will be able to kill these normoxic cells, which were hypoxic before. So that's why also it is an advantage for us to give radiation with fractions because they are becoming, the hypoxic cells are becoming more sensitive as there is a reoxygenization of the tumor. And the hypoxia is important during our treatments because the hypoxic portion of if the hypoxic portion of the tumor is large, and if the patient smokes during the radiotherapy or the hemoglobin levels are low, it can be because of the bleeding from the tumor, then there may be hypoxia in the tumor cells, and the free radicals generation will decreases, and the effect of radiotherapy will decrease. So we always check all these factors before beginning the radiotherapy. If necessary, we give blood transfusions to the patients. We insist not to smoke during the treatment, and we try to kill the tumor as much as possible. And the fourth factor was the repopulation of cells. And this is also an hormonal and homeostatic response of the cells against the reduction in cell population. Of course, it is something good for the normal tissues. It contributes to repair. And tissues that naturally turn over fairly rapidly repopulate earlier and more vigorously than tissues that turn over slowly. So for normal tissues, this repopulation is an advantage. But for tumor cells, this is their way to prevent to avoid themselves from radiation effects. When the tumor feels that it is decreasing the cells, it's dying, then as a response, it is increasing the repopulation, and we call this accelerated repopulation. So it means that the amount of cells to be killed will be increased. So the treatment should never be unnecessarily protracted because it is difficult to predict the accelerated repopulation response of individual tumors. Because we know that this accelerated repopulation happens after the 3rd or 4th week of the onset of the treatment. So it means that if we finish all the treatment in a short time, they will not have time to have acceleration repopulation. That's why we try not to give any breaks to our treatments during the treatment. Even we work in the holidays, in the bayrams, to finish it as much as short as possible. So as a result, why fractionation is needed? The aim of radiotherapy is to obtain a maximum tumor control with minimum side effects, which we call therapeutic ratio. And to deliver the effective dose to the tumor in a single fraction is not possible because of the side effects. So during fractionation, repair and repopulation of normal cells occur between the fractions, and redistribution and reoxygenation of the tumor cells occur as between the fractions, which is an advantage for us. And the fifth factor was radiosensitivity. Cells in the rapidly proliferating and dividing phase are more sensitive to radiation. On the other hand, we know that the cells with structural and functional features, which are differentiated to make a specific function in the body, such as bone, cartilage, or muscle, they are resistant to the radiation. So this is for the normal cells. And for tumor cells, we know that the tumors of different histologies differ considerably in their response to a course of radiotherapy, which is known the intrinsic radiosensitivity. And most of the time, the radiosensitivity of tumor cells is usually similar to the normal tissue from which they originated. So we can say that radiosensitivity of the tissue is directly proportional with the mitotic activity and inversely proportional with the differentiation level of the cell. There are two kinds of tissues regarding this aspect. First one is H-type tissues, which are radiosensitive. There are three different cell populations, like stem cells, intermediate cells, and the differential functional cells, which are bone marrow cells, gastrointestinal system epithelium, and skin and gonads. And these are more sensitive than the others, and they have acute response. They are acute responsive tissues. So it means that as their lifetime is short, because they have a continuous mitotic activity, they are giving acute response to the radiation. The damages in the stem cell compartment in this kind of tissues and occurrence time of acute reactions depends on the lifespan of differentiated cells. It can be between 2 to 4 weeks after we begin the radiation. And the duration of reactions is independent of the dose. We don't need a cumulative dose for that. Healing is with rapid proliferation of stem cells, and usually it is complete. So we are not too much afraid of this kind of reactions because most of them, they can recover completely. And severity and recovery rate of reactions are related to the total dose and the total radiotherapy time. So the early side effects of radiotherapy is related with these cells with rapid turnover. They have a highly proliferative compartment of the progenitor cells, stem cells, and the timing of the side effects depend on the lifetime of the mature cells, because when they will die, there will be no new cells as we stop the mitotic activity. And it may be after several days or weeks after the irradiation and can be recovered completely in a short time. There are also subacute responses, not very often, but what we call acute response is beginning from the radiotherapy until 3 weeks after the end of the radiotherapy. And subacute responses are between the 2 months and 6 months after the end of the radiotherapy. And these are reflecting the failure of a cell population with a longer turnover time. For example, the subacute pneumonitis, radiation pneumonitis, is a response like that. And the other type of tissues in the body is F-type tissues. They are more radioresistant. They are functional cells. They can have also stem cells. They can be also stem cells, but unless a very big need, normally they don't proliferate, and they are just making a specific function like liver, lung, kidney, muscle, brain, bone, and the others. And they are giving late reactions because the lifetime of the mature cells are very long, so we don't see them immediately. And the reaction severity is proportional to the dose per fraction and dose rate. Delayed reactions may improve. I mean, we can find some solutions, but most of the time they cannot be recovered completely. So these are the slowly proliferating cells, giving the late side effects of radiotherapy. It can be months or years after irradiation, sometimes 15 or 20 years after irradiation. Most of the time it occurs with vascular damage and parenchymal loss. And if there is a parenchymal loss, we know that it will be the fibrotic tissue will take place of these functional cells. And most of the time, the complete healing is not possible. So it means that when we compare the acute effects and late effects, we know that most of the time they are completely different kind of tissues, and the lifetimes are different, their jobs are different, and their recovery is different from each other. There is also a structural organization in normal tissues. We know that all the tissues are made up of functional subunits. For example, for lungs, the smallest functional subunit is acini. For kidney, it is nephron, and for liver, it is a lobule. So these subunits can show serial or parallel organization. And the side effects of ionized radiation vary according to the type of this organization, which can be, in serial organization, you can think it as the electricity organization. It is like a chain, and these functional subunits are interdependent, and it is shrinking in the functional subunits. And there is a limited migration feature of clonogenic cells, and the loss of one functional subunit affects whole organ function. It means that if there is a damage between these two functional subunits, it means that the function cannot continue after. So here it is very important the tolerance dose of this tissue, because with the maximum dose, we can give damage and we can lose all the function. So the risk of complication increases with the increased volume, of course, but the most important thing is the dose, tolerance dose. And the neurons are this kind of central nervous system, gastrointestinal system, skin, especially spinal cord and blood vessels are having this kind of organization. For example, if we have a hit in the spinal cord, it means that the organs under will not work because it's cutting all the nervous distribution to the body. Same for the blood vessels. If there is an obstruction, none of the tissues will take blood. So this is a serial organization. And there is another one, parallel organization. As you can see here, they are independent, autonomous, functional subunits, no migration in clonogenic cells. There is a threshold dose, of course, increases in small volumes, but threshold dose decreases as volume increases, and a certain volume of the organ must take more than a certain tolerance dose to lose its function. So it means that here, if there is a damage at that chain, okay, we cannot have the transfer of the impulse, but on the other side, the other chains can compensate the job, and we will not lose the function. These kind of organs are lungs and liver, and rather than the high tolerance dose, the maximum dose, the volume is important for this kind of tissue. So it means that if we give radiation, even if it is a high dose, to only a very small part of this kind of tissue or organ, we will not lose the function. The other parts will compensate the job. And there are also some organs which have serial and parallel subunits, and such as heart and kidney. They have both parallel tissues inside the organ and the serial organization, so they can be affected according to the which part we are giving the radiation. So it means in parallel organization, if the volume increases, the threshold will decrease and we can give more damage in the normal tissues. But in serial organization, exceeding the threshold, the tolerance dose, even in a small volume, may impair all organ functions. So I want to say that the radiation-induced normal tissue damage is related with lots of factors, not only with that tissue factors. Of course, the tissue sensitivity and radiation related factors are very important. The energy, the volume, dose per fraction, the interval between fractions, the total dose, the treatment time. But also there are some other factors which are affecting the tissue damage, like the external factors, patient-related factors, and other treatments. If we have combined treatments, if we give chemotherapy at the same time, concomitantly with radiotherapy, we will see more acute side effects because of the additional chemotherapy factor. For example, for age and race, if the patient is blonde with a very white skin color, she will be more, or he will be more affected than the black color skin about the skin reactions, as we have for the ultraviolet radiation. So, of course, all these things are important. This is a very confused table, but I just wanted to show that for many organs, we have the endpoint damage with the radiation. And what we have to do is to keep these doses for these radiotherapy volumes And TD 50 per 5 means this is the dose giving 50% probability in 5 years for this side effect. So you can see that with a little increase at the doses can increase the probability of side effects very much. So when we are making our treatment plans, we are always taking into account this, the first column, not to exceed the 5% probability to have the tumor control for the side effects. So I just want to talk a little about the acute big dose, large dose in a short time, which is the case in the accidents or the atomic bomb, what's happening in the body. I know my time is over, but it will take just a few slides. We have some radiation syndromes after acute radiation accident. This is the whole body radiation. I'm not talking about the radiotherapy. There is a prodromal syndrome at the beginning. It begins soon after the irradiation and it persists for up to several hours. And there are some transient neuromuscular and gastrointestinal symptoms, and the severity and duration of these symptoms increase with increasing doses. And then the main three syndromes of acute doses can begin. So the first one, according to the time, will be cerebrovascular syndrome. The onset of symptoms are almost immediate after the exposure. They are severe gastrointestinal and neuromuscular disturbances, and it is invariably fatal, and survival time is not longer than around 48 hours. It occurs with the total body doses in excess of 50 gray. So this is with the higher doses. If the total body dose is more than 50 gray, we are losing the people in 2 days, and it is a very big chaotic syndrome. The second one is a gastrointestinal syndrome. It occurs with a total body dose of over 8 gray. And the people, they will have vomiting, diarrhea, dehydration, electrolyte imbalance, malabsorption, weight loss, and lethargy, and at the end, sepsis. And we lose the people in between 5 to 10 days. And it is progressive. It has progressive symptoms, and no human can survive with a whole body dose of 10 gray of radiation. And the third one is the hematopoietic syndrome, occurs with total body doses of 2.5 gray or more, between 2.5 and 8. And it is a consequence of the killing of bone marrow stem cells and lymphocytes, characterized by a fast reduction in the peripheral blood lymphocyte count over a period of 2 to 3 weeks, a more gradual reduction in the numbers of the cells, leukocytes, platelets, and erythrocytes. And the reason of the death is infection and or hemorrhage, because of the granulocytopenia and thrombocytopenia, which reaches a maximum within 30 days. And there is only one way for survival, that is the bone marrow transplant. If we can make at time a bone marrow transplant, which can be successful, then we can survive the victim. If not, we cannot. So thank you for your attention. And if there are any questions, I'm ready. I cannot hear you.
Thank you very much for your interesting presentation, Professor Nalçı Andreou. It was really, really amazing for me to hear all these detailed information about radiation therapy, especially well, actually, in veterinary medicine, we have very limited possibilities for this area of radiology. But if you don't mind, I have a question. You gave us so many data and information on the factors which have an effect of planning radiotherapy. It depends on the patient, the tissue properties, and the phase of division, and all these things. Before we start this, of course, we take samples and send them to the pathology lab, where they are coming to a histological diagnosis before you start. But I wonder if they only do a diagnosis, or if they also investigate some properties of the tissue which you might use for planning the radiotherapy.
Of course, we need absolutely the pathology report before beginning the radiotherapy. There are two reasons for that. The first one is for our indication to give radiotherapy, because it is also giving us some pathologic prognostic factors that if we need to give adjuvant radiotherapy or not. And the second one is it is giving the differentiation of the tumor cells, so that we can understand that if it is a rapidly growing tumor or not, because of this grade factor, the differentiation of the tumor cells. If it is a high grade, if it is less differentiated tumor, it means that this is a fast growing tumor. And in fact, it is not a good prognostic factor, but they are more radiosensitive to the therapy, as they have a more mitotic activity because of the less differentiation. We can affect them more with radiotherapy and chemotherapy. So, of course, they are giving us very valuable information for planning our treatment.
Okay, thank you. Now, I wonder if there are any other questions from the audience, maybe. But I don't see any questions. Ternoja, do you have any questions on the monitor? I don't see any.
I would like to thank the symposium chairperson, Prof. Dr. Meltem Nalcha Andrew, for her perfect presentation and also perfect organization. Thank you.
You're welcome. I thank you.
Yes, now the last presentation of the first session of our Ionizating radiation and its effects on human health symposium will be presented by Dr. Yasemin Küçüklioğlu. I want to give a short CV of Dr. Yasemin Küçüklioğlu. She was born in 1979 in Burdur, Turkey. She completed the Ankara University Faculty of Medicine in 2003. Between 2004 and 2010, she has done her radiology specialty training in the radiology department of the Izmir Tepecik Training and Research Hospital. Her work experiences started with the radiology department of Izmir Tepecik Training and Research Hospital in between 2004 and 2010. And then her work experience continued with as a radiology specialist in Bitlis Public Hospital, Antalya Private Akdeniz Şifa Hospital, in Antalya Private OFM Hospital, and starting from 2017, Dr. Yasemin Küçüklioğlu has been continuing her studies as a radiologist specialist in the radiology department of nearest university and in the nearest university hospital. Now, we would like to invite Dr. Yasemin Küçükçiloğlu to present her presentation entitled with Radiation Protection.
Thank you, Dr. Adala, and I want to thank the Symposium Committee for their invitation. Today, in this session, I'll try to discuss the protection methods of radiation, different exposure situations, and the protection methods, and the history of the progress of these protection methods. But first, I want to start with the description of the radiation risk. This term is used to determine the detrimental health effects of radiation exposure or any other safety risks as a consequence of exposure to radiation, a presence of radioactive waste, or a loss of control over a nuclear reactor core, nuclear chain reaction, or any source of radiation. And the aim here is the protection of the radiation workers, the public, and the environment from the harmful effects of radiation. Our goal here is to prevent the deterministic effects like death, skin effects, cataract, or infertility, and to minimize the possibility of stochastic effects like genetic diseases and cancer. And I will start with the history of the protection methods. With the general use of the radiation, the harmful effects were observed, and more than 50 cases were published until 1902, and an increase in leukemia incidents were observed, especially in the radiology workers. Muller revealed the genetic effects of the radiation in 1927, and in 1944, it was revealed that radiology workers were 10 times more likely to have leukemia than the public. And as a result of these observations, some organizations, especially within the United Nations, were established. One of these organizations is the United Nations Scientific Committee on the Effects of Atomic Radiation. It was established in 1955 and reviews the natural and artificial radiation sources that people are exposed to in their environment. And another organization, not an official organization, but a scientific commission, International Commission on Radiation Protection. This commission was established at the Second Radiology Congress in 1928. This organization prepares recommendations on radiation protection. And with the increased knowledge of the effects of the radiation, the recommendations changed in time. In their first recommendation, the upper limit was 1 sievert per year for public. They recommended the ALARA principle in 1973 as a gold standard, and in 2007, the upper limits were 20 millisievert per year for radiation workers in 5 years average, and 1 millisievert per year for public in 5 years average. Another organization is International Atomic Energy Agency. Is an independent organization, but operating within the United Nations, and prepares nuclear security standards. The target groups for these basic safety government and the regulatory agencies, the health authorities, and the technical authorities. In these safety standards in 2011, the types of exposure situations were discussed in 3 parts: planned exposure situations, emergency exposure situations, and existing exposure situations. As the name signifies, planned exposures is a situation that arises from a planned activity. And since the provision for protection and safety can be made before the activity, the exposures and their likelihood of occurrence can be restricted from the outset. And this can be controlled by good design of facilities, equipment, and operating device procedures, and of course with training of the people. Planned exposure situation can be discussed in three groups. The first, medical exposure, second, occupational exposure, and then the public exposure. In medical exposure situations, the basic medical function of diagnosis and treatment takes priority over protection, and because of this, those limits cannot be applied for these situations. But of course, the unnecessary use of radiation must be precluded. In the for the occupational exposure, the protection starts at the source with shielding. And in the environment, ventilation and additional shielding helps protection. And in person, of course, working practice, protective clothing and devices. And simple measures can be used to reduce personal radiation exposure. The first one is limiting the time of the exposure. The second, increasing the distance from the source, and of course, use of shielding. For public exposure, the first step to reduce public exposure is to control the source of the exposure. In emergency exposure situations, the exposure arises as a result of accident or a malicious act or any other unexpected event and requires prompt action. Preventive measures must be considered before this situation occurs. But once an emergency exposure situation actually occurs, exposures can be reduced only by implementing protective actions. Existing exposures is the exposure due to residual radioactive material from the past activities or the remains of patients, and the exposure already exists when a decision for control needs to be taken. This also includes the exposure to natural background radiation. At this point, I want to make a note of Chernobyl. Some of the villagers turned back their homes in Chernobyl, and for last decades, some animals are photographed in the area. They started to live there. Some wolves, bears, even horses are pictured. And long-term observations will show us the consequences of the exposure of these people and animals. And finally, I want to talk about the dose concentrates and the reference levels. The upper limit is 1 millisievert for the individuals. That yields little or no benefit for of the radiation, but which may benefit society in general. And the limits between 1 to 20 millisieverts benefits the individuals. This term is used for the public exposures in the existing exposure situations, and 20 to 100 millisieverts are the limitation is used for the individuals that are exposed to radiation from sources that are not or under control, and a dose of greater than 100 millisievert is considered unacceptable. But there's an exception for this situation. The radiation emergency workers, the upper limit for these workers is 200 millisievert. In summary, time, Distance and shielding is important to reduce the occupational radiation exposure, and preventive measures have to be considered in a possibility of an emergency situation. And the reference levels must be considered and applied for all situations of radiation exposure to reduce the effect of the radiation for the radiation workers, the public, and the environment. Thank you for your patience. I think I was too fast.
Thank you so much. Thank you so much, Yasemin Hocam. Let us ask whether there are any questions from the participants. Is there any question? There is one question from Professor Dr. Murat Özgören. He asked whether is there any effect of nutrition? He asked.
There is no publication about the effect of nutrition, but I think we may have to focus on these situations, because there is the background radiation from the soil and the air started to express more and more in our daily lives, but I don't know about it.
I think the question is going to be one of the questions related with the presentation of Prof. Dr. Meltem Nalcha Andrew. And I'm gonna ask Professor Dr. Meltem Nalcha Andrew the question of Prof. Dr. Murat Özgören, which is related with the nutrition, effect of nutrition. He asked whether there is any effect of nutrition. Hocam?
Yes, yes, of course. Nutrition is, in fact, I showed a table, and there were some other external factors about the effects of radiation, ionized radiation, and we can take the nutrition from this group. First of all, for the tumor, in the last years, there are many, what I can say, opinions, because it is not completely proved yet, that as the tumor cells are using the sugar, it is written in the newspapers like that, sugar, everybody is trying to stop sugar, to income of sugar. When they have cancer, they think that they are feeding their cancer. But we all know that sugar is a carbohydrate, and you can take some other carbohydrates instead of sugar. And also some of the fat tissues, to take too much fat can turn to carbohydrates in the body. So we cannot say that the nutrition is affecting directly the tumor control, because it is not completely proved yet. There are some nutrition materials which are known that they are decreasing the free radicals in the body. So it means that they will not maybe change the treatment or change the response to treatment, but to have a cancer, they will prevent the cancer production because of this free radical prevention. On the other hand, for the normal tissues, it is a very important factor, nutrition, if the gastrointestinal system is inside the treatment field, because we know that with the effect of the, for example, the too hot, too cold, alcohol, too much acidic food, they are all affecting, they are making irritation in the mucosa if the gastrointestinal system is in the radiotherapy treatment. So they are increasing the side effects because of these irritations. But this is as an external factors.
Hocam, thank you so much for your excellent answer for this question. Thank you. Now, it's the end of first session of our symposium, Ionizating Radiation and its Effect on Human Health Symposium. Now, the second session of our symposium will be held on at 1:30. So let us meet together at on time. You can use the link that we share with you, and we will discuss with new presenter, new researcher, the topic of today. Thank you.
Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, ilerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.